These are all post-traumatic ankles. The upper two are recent, the other is somewhat later. Can you tell what the pathology is from the photographs, and what tests would you carry out to determine the pathologies or the need for referral to the emergency room? This webinar will be looking at a functional way of assessing non-structural leg length discrepancies, rather than using non-weight bearing methods which do not necessarily have any real functional carryover. In order to do that, we'll be looking at stance, gait, and the presence of dysfunction. And in order let's look at some causes of non-structural leg lengthening, starting from the top of the diagram and working our way down. Anything that supinates or inverts the weight-bearing foot, including dorsal subluxation of the medial tarsals, inversion subluxation of the calcaneum, and anterior or medial rotation subluxation of the talus. Hip extension, hypomobility, but only during gait, not unless there is gross flexion fixation in standing. If the hip cannot extend, then the stride length is shortened and the leg length is increased from mid-stance to toe off. Causes include lateral rotation subluxations or anterior subluxations, commonly called euphoes, primary extension subluxation of the innominate, OA and labral entrapments. At the SI joint, inferior or downslip subluxations and primary extension subluxations of the innominate, and in the lumbar spine, flexion subluxations and a Mackenzie shift, or what is probably a transverse subluxation. Of these, the hip and ankle subluxations are the most influential, followed by foot issues, and the least influential being the SI joint and lumbar joints. I'd just like to clarify some terms that I'll be using so that we can all be using the same language. These definitions are specific to the topic at hand. The first is compensation. It means anything that the body does that tends to equalize discrepant leg lengths. So orthotics would not be covered in this definition and may better be called corrections. Second, overcompensation is where, because the stress is too great to be tolerated, the tissues go past the point where they can tolerate the forces placed upon them. They may then break down, that is, fail by becoming stress fractures, ligament laxities, tendinoses, degenerate muscle tears, etc. In effect, a long-legged responds to body weight and ground reaction forces by shortening, as these forces compress and rotate it medially, flattening the foot, dorsiflexing the ankle, spreading the mortise and pushing the fibula up and outwards, thereby gliding the superior joint posteromedially. The knee hyperextends and valguses, and the innominate anteriorly rotates on the femoral head, flexing the hip and extending the sacroiliac joint. The lumbar spine forms a concavity to the long side, thereby extending the facet joints. All of these effects will tend to compensate for the long leg by shortening the whole quarter, while on the other side the reverse occurs, with the foot supinating, or more commonly inverting, the ankle plantar flexing, the knee taking up a neutral position, and the innominate posteriorly rotating, thereby extending the hip. The lumbar spine will form a convexity on the short side, flexing the joints. To look at what shortens a leg, you can take the compensations and overcompensations for a long leg and shift them to the right, while the compensations for a short leg are shifted to the left. What compensates for a long leg causes a short leg. There is often confusion about the anterior rotation of the innominate on the femur as to whether it lengthens or shortens a leg. It does both, depending on the context. If you lay a person supine and then passively rotate one pelvis anteriorly and the other posteriorly, you will see that the leg on the anteriorly rotated side gets longer as the leg is pushed down the bed, while that on the other side shortens as it is pulled up. This is presumably what happens if the innominate undergoes a primary subluxation on the sacrum with little weight on the foot. But the same subluxation can occur while the foot is on the ground and under full or near full weight bearing. In this case, the leg cannot be pushed downwards because the ground is in the way. But instead it flexes the hip and causes compression through the leg, forcing the compensation seen in the long leg. In truth, this doesn't happen as stated. Instead, the subluxation is slow as the habitual force from the long leg results in exhausted adaptive potential and the consequential subluxation. So it really doesn't cause the compensation, but is part of it. To picture the effects of leg length discrepancy, stand with your feet about 1/3 of a metre, around a foot for the metrically challenged, and twist to the right. Not like the dance, but rotate around a vertical axis without rolling onto the sides of your feet. If you did this on a trampoline, your left foot would indent the material and your right foot will release tension on it. But on a firm matrix, your legs must adjust themselves to deal with the weight transfer to the contralateral foot. As the contralateral leg takes the weight, it is squeezed between your body and the floor and immediately rotates throughout its length, so shortening, while the ipsilateral leg tries to lift off the floor and must elongate to stay in contact with it, so it stretches. Similar things are happening to the spine, with the weight-bearing side extending and so forming a concavity contralaterally and the other side flexing. You will see your left foot flatten, that is pronate, and your right foot invert, not supinate. The left knee will valgus and extend, while the right will varus and unlock from the extension. It doesn't quite flex, but it wants to. What you can't see is the left innominate anteriorly rotating and the right posteriorly rotating. In effect, the contralateral leg medially rotates, while the ipsilateral leg laterally rotates. If there is perfect compensation for a leg length discrepancy, these can be seen in quiet, symmetrical and neutral standing. Assuming the left leg is long, as in the slide, the left foot will be pronated more than the right, with lower arches and a slightly everted calcaneum. The knee will be more locked than the left and slightly valgused, and there will be deviation of the pelvis to the short side, at least osteochromatically speaking, with extension of the lumbar facets on the left and flexion on the right. That is a scoliosis with concavity to the left and convexity to the right. The opposite is happening with the leg on the short side to compensate. Just in passing, if you do see a slightly more pronated foot, do not rush to stick an orthotic underneath the arch, as if this is trying to compensate for a long leg, you'll cause breakdowns elsewhere. I have three functional methods of assessing leg length inequality to discuss with you: stance, gait and dysfunctions. Generally two and sometimes all three are used to assess for discrepancy. These are for the most part screening tests to reduce not only what needs to be examined but also what movements need to be examined, thereby shortening the amount of time spent on this aspect of etiologically searching. First, we can observe the compensations. These include the medially rotated long leg with pronated foot, over dorsiflexed ankle, hyperextension and valgus of the knee, and the ipsilaterally extended spine. We can also look at the short leg, the lateral rotation with an inverted and sometimes supinated foot, the slightly plantarflexed ankle, the unlocked knee, and the ipsilaterally flexed spine. That is a mobile scoliosis convex to the short side. We can also look to the general stance of the patient, more precisely a lateral lean towards the shorter of the two sides, which occurs regardless of whether we are in the presence of a lengthening or a shortening of the leg. This lean is often best seen by imagining a plumb line drop from the belly button to the floor and seeing if it falls off to one side. But if the compensations through the two quarters are perfect, this doesn't work and the lean is not visible unless you screw up the spinal compensations. One way to do this is to correct the pelvis shift and look again. This might mean a second person holding the pelvis correction while you look, or a mirror that you can look into while you hold the correction. But it is a functional method of assessing for leg length issues. In the case where the inequality is caused by hip extension hypermobility, looking at stance will not help, as elastic extension is only necessarily near and at the terminal phase of weight bearing. That is from mid-stance to toe off. Gait observation is required to see this aspect of inequality. It is worth stating at this point that a short leg is not the equivalent of a long leg on the other side. Using the terms long and short implies that the leg is longer or shorter than it should be, not simply longer or shorter than the other. The stance and the gait of a long leg and a short leg are totally different. The gait of a person with a long leg is entirely different from that of a person with a short leg, again longer or shorter than it should be. The dysfunctions caused by the long leg are entirely different from those caused by a short leg. The two words are not interchangeable. Have the patient walk at a reasonably brisk pace and observe the top of the head and the sides of the shoulders. You are looking for either the shoulders to drop to one side and it looks as if the patient is trying to walk sideways, or for the head to bob up and down as he or she steps onto the long leg. This looks as if he is vaulting over the leg and can sometimes actually be felt by the patient. The first gait is a lateral limp and indicates a short leg on the side towards which they are dropping, while the second is a vertical limp indicating a long leg on the side on which they are bobbing up. Very, very occasionally you will see them do both. Lateral off one leg, vertical off the other, indicating a long and short leg. If you want to feel the vaulting of the long leg, leave one shoe on and walk. It is very distinct, but the feeling disappears over time, longer than you're likely to be doing this for, providing you are not wearing high heels, as the body compensates for it, although many patients can feel it if it is pointed out. However much of that is real and how much suggestion, I don't know, but I do know that whenever I feel that I know that I am walking on a long leg, I am due for a period of me hearing me whining about my back. There are 5 possible gaits that are significant for assessing leg length inequality. First, a vertical limp from a long leg. Second, a lateral limp from a short leg. Third, a vertical limp off of one leg and a lateral limp on the other, caused by a long and short leg respectively. Fourth, no limp. which can either be due to leg length equality or a perfect compensation, and an antalgic gait, which tells nothing about leg length discrepancy and screws up any observations you may make. And wait for it, a long leg causing a lateral limp. This last is because sometimes the overcompensations in the long leg can be extreme due to inability for normal compensation to be sufficiently achieved at all joints available. This is sometimes because one or more joints in the long leg are unable to achieve full range to shorten sufficiently, or sometimes because the short leg cannot lengthen enough because one or more hypomobilities prevents this from happening. The result can be that the ones that can fully compensate cannot accept the level of stress they are made to take because they are taken on much too much on themselves, and breakdown occurs to such an extent that the long leg then becomes short. For example, the long leg is unable to dorsiflex at the ankle sufficiently, so that the knee is first forced further and further into extension and valgus until the MCL is overstretched and a valgus instability occurs to such a degree that the leg can actually become shorter. The only way you can deduce this is if you find a major cause of lengthening in the short leg. Not frequent, but it does happen, so look for it. Antalgic gait is the result of a patient avoiding pain while locomoting, and usually involves walking on the lateral side of the foot or the toes to avoid the painful area and to get the weight off the foot as quickly as possible. The gait completely precludes you from determining any leg length discrepancy, so don't bother looking for it. Patients attending because of pain, pathomechanical or structural. That is a biomechanical dysfunction or a pathoanatomical lesion, which includes unexplained non-traumatic arthritis of minor amounts, tendinosis, ligamentous instability, etc., with no history of trauma, systemic arthritis or other joint swelling, unfamiliar overuse or similar. You can then give some thought as to whether the problem would shorten or lengthen the leg. For example, a straight valgus instability of the knee without a history of traumatic rupture would of course shorten the leg, but the question is what caused the ligamentous instability? And one answer, the easiest to check, is that a long leg overstressed the ligament and basically made it lax. You are sensitized to look for a long leg, and if the leg is observed to be long from observation of stance and more importantly gait, then it is highly probable that you found the general cause of the instability. Now all that remains is to identify the cause of the long leg. Look for a minimum of one major cause, or more usually two or more leg lengtheners, often one major and one minor. So generally the search for a length discrepancy starts with the patient's diagnosis, pathoanatomical or biomechanical, when no obvious cause is forthcoming. Understand how the dysfunction may have been caused by a given inequality and go look for it. In general, a long leg will mechanically stress joints and bones, leading to stress fractures, articular instabilities, hypermobilities and subluxations, while the short leg tends to require muscular effort over a prolonged period to maintain the elongation, and so the result is more of a muscle tendon pathology such as degenerate ruptures, tendinosis, shin splints, etc. The next few slides will look at a few more painful conditions and how they relate to leg length discrepancy. Third method is to look at the various dysfunctions in the leg and assume that it will make a long or a short leg. If you don't see it, then you have good compensation or perfect compensation going on. The patient is attended because of pain, pathomechanical or structural, that is biomechanical dysfunction or pathoanatomical lesion, including unexplained non-traumatic minor arthritis, tendinosis, ligamentous instability, etc., all with no history of trauma, systemic arthritis or other joint swelling, unfamiliar overuse or something similar. You should then give some thought to whether the problem would shorten or lengthen the leg. For example, a straight valgus instability of the knee without a history of traumatic rupture would of course shorten the leg, but the question is what caused the ligamentous instability? And one answer, the easiest to check, is that it is part of a long leg. Doing it this way, you are sensitized to look for the long leg, and if the leg is observed to be long from observation or stance, and more importantly gait, that is highly probable that you found the general cause of the instability. Now all that remains is to identify the cause of the long leg. Look for a minimum of one major cause, or more usually two or more leg lengtheners, often one major and one minor. So generally the search for leg length discrepancy starts with the patient's diagnosis, pathoanatomical or biomechanical, when no obvious cause is forthcoming. Understand how the dysfunction may be caused by a given inequality and go look for it. In general, a long leg will mechanically stress joints and bones, leading to stress fractures, articular instabilities, hypermobilities and subluxations, while short legs tend to require muscular effort over a prolonged period to maintain the elongation, and so the result is muscle and tendon pathologies such as degenerate ruptures, tendinosis, shin splints, etc. The next few slides will look at a few of the more painful conditions and how they relate to leg length discrepancy. Just to recap before we get into examples, the main gaits found that have a bearing on leg length inequality and their causes. They are a vertical limp caused by an ipsilateral long leg and forcing shortening compensations on that side and lengthening on the other. In my opinion, the most injurious leg length of issues generally resulting in instabilities, hypermobilities and subluxations. A lateral limp caused by an ipsilateral short leg, which results in lengthening compensations on that side and shortening on the other side, mostly causing contractile lesions, or no limp caused either by no inequality or by perfect compensation, which can usually be seen in standing. Let's look at a very common example. Low back pain caused by an extension subluxation of the, we'll say, right lumbosacral junction. This is a very common condition, but one that most therapists think of as a primary lesion, and sometimes it is, but you should make sure of that before assuming it. We start with the diagnosis at the left side of the diagram. That is a right L5-S1 extension subluxation. We know that three things are likely to cause it: right hip extension hypomobility, a flexion subluxation of the right SI joint, and a long right leg. Generally speaking, the closer the stressor is to the symptomatic tissue, the more potential it has for causing the problem. So the hip and the SIJ are the most likely causes, but not exclusively so. We also know that a primary extension subluxation of the SI joint will cause a right long leg, but more commonly this subluxation is a result of overcompensation for a long leg, and is also part of the effect of anterior torquing that the hypomobile hip causes at the pelvis and the lumbosacral junction. So we look for a long leg using Gait. If it shows us long, we have the compressive and torsional forces potentially causing the lumbosacral dysfunction, and if short, then the flexed innominate mechanically overstressing the lumbosacral junction and causing it to overextend is likely. Understanding that looking for a right long leg using Gait is simply a screening test for the hip and other causes we can assess for etiology and contributors. Clearly the symptomatic joint has to be treated. Manipulation and rehab are the best treatments, but if the abnormal mechanical stress isn't removed, then there is every reason to expect a recurrence, regardless of how good the rehab is. If the joint failed once while healthy, it will do so again when undergoing this same stress. If there is no limp, then either there is a perfect compensation throughout both lower quarters, or there is overcompensation somewhere with breakdown coincidentally equalizing the legs. It is unlikely that there is perfect compensation when a major cause of leg lengthening is present, so a breakdown is more likely. Once the cause of the long leg is dealt with, the breakdown, which is likely the knee or the foot in its source, must be sought. It is a breakdown. If it is a breakdown, reassessing the gait after treating the major cause of the long leg discrepancy should now show a short leg instead of a long leg. If the knee is valgus, then that might have to be lived with. But if the foot is at fault, then the arch needs a support or a heel cup. If a short leg is found, but not the flexion subluxation of the SIJ, then it is likely that the short leg is irrelevant. But if the SI joint is found to be problematic, then it should be manipulated to remove the stress from the symptomatic joint. If a vertical limp is observed, then the cause needs to be sought. This is likely to be the hip, and you are also likely to find that the SI joint is subluxed into anterior rotation, as it is flexed to overextension by the hip hypomobility. If the hip is mobile, then likely the ankle or the foot is at fault, and this should be dealt with. Almost everything else you find will be a contributor. Joints that are unable to enter into the compensation or overcompensations. These overcompensations may become issues once the major cause is treated, but they are unlikely to be very influential. First, what is the pathology? Is it inflammatory or degenerative? That is it tendonitis or tendinosis? Tendonitis is actually quite uncommon in our practice. The pain is extreme, the tenderness is exquisite, and present almost before you touch the tendon. In fact, it requires very little contact to bring on the pain. And both stretch and contraction tests are very, very positive, with isometric contraction testing resulting in painful weakness. It is caused by direct trauma, medical conditions such as rheumatoid arthritis, gout, etc., and severe and very unfamiliar overuse, but almost never by long-term stresses such as familiar overuse and, in this case, leg length discrepancy. So we are looking at tendinosis. In this case, the tenderness has to be searched for and is much less severe. Generally one or other, but often not both, of stretching and contraction testing are positive, and sometimes neither are positive. In the last case, the patient reports that the pain comes on sometime during the activity rather than immediately. So for the purposes of this exercise, we will say that this is a tendinosis. Next, what is the function of the muscle? It dorsiflexes the foot during gait and maintains the medial arch on locomotion. If the arch is being forced downwards, the muscle needs to hold it up more than it would normally do, and so it can break down. If not the tendon, then the muscle itself, and then we can see anterior shin pain. So, tibialis anterior tendinosis, is it caused by leg length discrepancy? I would say yes, among many other causes. In this case, it would be caused by either an ipsilateral long or more usually by a short leg. The tibialis can be overstressed by both a long leg and a short leg. Let's look at the short leg first because it is less complex. If the short leg is caused by a collapsed foot, from whatever caused the tibialis anterior, we'll try to maintain the medial arch and hold the weight-bearing foot in inversion. Over time, this can easily result in an occult but nonetheless true overuse syndrome, resulting in degeneration of the tendon or the muscle and possibly pain. With a long leg, the same thing can happen on the opposite side. If the foot must overcompensate because it is carrying out too great a role because some of the joint is unable to share the load, the foot collapses and the muscle tendon overworks and degenerates. It is exactly the same as before, but the cause of the collapsed foot is overcompensation, whereas the collapsed foot was the cause of the short leg. With a long leg causing ipsilateral tibialis anterior problems, it is because the foot collapses as it must overcompensate for the long leg and other joints cannot do their part. So in all cases, the cause is because of a collapsed foot. At some future webinar, we can start to look for causes of the causes. But this search eventually breaks down and sort of moves towards an infinite regression. But for now, this will do as you try these observations for yourself. The process to follow that will probably work is 1. Diagnose the pathomechanical entity or the pathoanatomical lesion. Decide if it is likely to be caused by a long leg or a short leg. That is it overcompensating? Predict the gait pattern you will see and assess stance in gait. If it's not there, either the problem is not caused by leg length inequality or the diagnosis is incorrect. If there is a leg length discrepancy and limp, look for the cause of it. Deal with the primary diagnosis, deal with the etiologies and contributors, reassess the gait, then establish in your own mind if this works or not. Anyway, happy experimenting and have a good week. Bye. The top pair are very similar to each other. One is a lateral ligament tear and the other is a fractured lateral malleolus, but which is which? You could do much worse than utilise the Canadian foot and ankle rules when you're examining the patient. This was covered in an earlier webinar, but essentially you are looking for any of the following. Tenderness along the posterior edge of the lateral malleolus for about 6 centimetres or 2 inches. Inability to take 4 steps either immediately after the injury or on the tendons. But the left-hand photo is of a ligament tear and the right is of a malleolar fracture. The bottom picture is of a post-inflammatory hyperpigmentation. This is a skin reacting to inflammation in some people, especially those with darker skins. It is an excess of melanin and it is not a threat to life or function, but doesn't look very nice. It is easy to see this once bruising has gone down. Hypopigmentation, the opposite response to inflammation, and consists of reduced melanin and whitening of the skin.